saying that before. Phenomenological approach and community-based participatory approaches to improve respect in research. Did you see this, Mike?
Okay, let's talk about community-based participatory research. It's the ethical standard for conducting research in populations worldwide. In community-based participatory research, which I'll call CBPR from now on, researchers and communities partner across the entire trajectory of research, from project development through data collection, analysis, publications, return of results, translating those results into changes for the communities. The goals of this research paradigm is to increase respect, trust, and benefit. So they increase respect of research participants, increase trust of the research process and researchers, and increase benefit for communities that are participating in research. Particularly for health-related studies, this means to improve, the goal is to improve the health of participants and communities. So the goal of doing research is to improve health, right? I don't think anyone would argue with that. But does CBPR actually work? Does it accomplish the goals that we hope that it does by using these methods? And in the short term, it seems like it does. So we see an increase in the trust of the research process and researchers. There's an increase in the uptake of interventions that are trying to be implemented in communities. And there seems to be an improvement in health for people who participate in research. But in the long term, it's a lot harder to figure out whether CPBR is working. Is it actually improving health long term in communities? And one of the reasons this is so hard to figure out is because it's really hard to measure health outcomes in communities where we're not actually measuring outcomes, right? So if you're conducting research in a community, you can figure out what's happening in that community. But unless you're also conducting research in a community where you're not conducting research, you can't know what's happening in that community to compare it to. So we can't figure out whether the changes that we're seeing in a community are the result of what we're doing in the community, or whether it's just happening anyway. Because we hope that health is improving over time, regardless of whether we're actually the ones causing it or not. So this is the question that we try to answer in some of our recent work. Does ongoing community-based participatory research improve health in participating in communities, even among community members who are not actively participating in research? Does the process of doing CBPR improve health in communities generally? In the setting that we conducted this project in is the Yukon-Kuskokwim River Delta. And for the rest of this presentation, I'm going to go into this framework here. I'll tell you a little bit about this region and how this creates such a perfect environment to be able to answer this question in a way that we can't in other settings. And I'll talk about this EHR-based study investigating cardiometabolic health changes in communities that did and did not participate in ongoing CBPR. So the region of the YK River Delta is the western part of Alaska. You can see the state of Alaska here in blue on the bottom corner. And then the YK Delta is highlighted in yellow. So you can see where that is. It's a fairly large region. It includes 58 remote communities that include about 25,000 people. This entire region is served, all the healthcare in this region is provided by the Yukon-Kuskokwim Health Corporation. So one healthcare system provides care for this entire region. And it's divided into systems of care where we have one major hospital, and that's based in Bethel. We can see with that star there in the middle of the map. And then there's 5 regional subclinics. And so each region is classified as a different color. So there's one sort of mid-level hospital in each of those colored regions. And then each community itself has a community clinic. And that's staffed by a health worker. So anything that would require medical attention from an MD or a more specialized care would be in one of these regional clinics, and then more of your inpatient care would happen exclusively in Bethel. Anything that's truly specialty, so think of cancer care, organ transplants, things like that would happen in Seattle or in Anchorage. But all routine care would happen through this healthcare setting. So embedded within this environment, we have ongoing community-based participatory research. And my collaborators who I work with are shown in the middle here, Scarlett Hopkins and Bert Boyer. And for 20 years, they've been conducting CBPR in 10 of these communities. And these 10 communities were chosen specifically because they represent the diverse features of the area. So it's a collection of 10 communities that represent sort of generally inland versus coastal communities, prevalence of diabetes, some of the other factors that may differ across communities are supposed to be represented in these 10. And it was chosen by, those 10 communities were chosen by the YKHC Health Corporation. They've been conducting several studies over the past 20 years related to cardiometabolic health. Many of these have to do with genomics. Others have to do with lifestyle, dietary, other factors that may influence cardiometabolic health. So they started their research with the classic CBPR approach. They spent 2 or 3 years doing research prep, where they met with tribal councils, community members, trying to figure out a good protocol, good research questions even, to conduct their actual studies. And then between 2003 and for this study, 2012, although it continues to today, within this time frame, they conducted 40 data collection trips across these 10 communities. And that ended up being about 2 to 8 visits per community. And on these visits, they stay in the community for 2 to 3 weeks. They meet with community members, they gather data, they recruit participants, they talk to the individuals and the tribal councils. And they work very closely with the Ucaycuscoquim Health Corporation. That's the healthcare organization that provides the care. And the medical director at the time, who's now the director of quality, Dr. Cueca, would go to these communities, and he noticed that the people who participated in research were very vocal about their participation. And he said the CBPR participants, they want to share their study results. They are talking to their study participation with the other members of their community. They know what their results mean. They're engaged in this research process and the health information that comes out of it. And wouldn't it be really interesting if the CBPR process raises community awareness of cardiometabolic risk and protective factors generally? And do you think there's any possibility that we could possibly measure this? So this question that I'm talking about comes from a community member. So I think it's kind of a meta CBPR and a CBPR type process. So this is what we tried to do. And the Ucaycuscoquim Health Corporation is a really unique place to be able to do this. So remember I said that it covers the entire area where these communities are. It has electronic health records that go back to the early 1990s. So a fairly long time when we can have this, we can gather medical records. It has comprehensive care for everyone. So every piece of care that someone gets, besides these really specialty care, is going to be represented in the same health system. And this one health system covers everybody in that area. So whether or not somebody lived in one of those 10 communities, we have medical information on their, on how they interacted with the healthcare system. Importantly, although the healthcare system collaborates with the CBPR process, healthcare and CBPR are independent. So nothing about the CBPR process would affect healthcare. The healthcare that somebody gets would be the same, regardless of whether the person is participating in research or not. There's some referral that goes back if there's a concerning lab result, for example, in CBPR, those people are referred to the medical system again, but other than that, all care should be the same. And because this healthcare system has been serving people in this area for a really long time, the longitudinal records exist from before CBPR began through current day. So we can get not only records from communities where CBPR happened and CBPR did not, but also from before when the CBPR process to after. So a few ways we can compare this. And as a result, unlike other CBPR studies, we can study communities and individuals who are not actively engaged in research directly, because this is a separate way to measure all of their health outcomes, as opposed to what's collected through the CBPR process. So this is what we did. We collected all EHR data from 2002, which is right before the CBPR visit started, through 2012. And we had about 9,000 people who lived in communities where there was never a CBPR visit. There was no ongoing CBPR study, and about 3,500 people in communities where these CBPR projects were happening ongoing over the 10 years. You can see that they're fairly similar age, similar sex distribution. The control communities, so these are the communities where no CBPR occurred, are a little bit farther from health clinics. But other than that are fairly similar. The people who live in these study communities do tend to see the healthcare system a little bit more often. And you can see that about a quarter of the people who live in CBPR communities have participated in at least one study. And then among the entire community, the average number of studies that someone has participated in, this could be between 2 and 8, is about half of a study. You'll see that there's a few people who live in these communities where no CBPR happened who have participated in studies. And that's because if someone's visiting someone in a CBPR study and community and there's a study going on, they're invited to participate and they're not excluded from that process. So there is a little bit of fuzziness there, but not much. It's pretty set. We did exclude people who live in Bethel because the idea is that their healthcare would be better since they live in this the specialty care area. So the first step to doing EHR-based research is to clean the data, right? EHR data is notoriously messy, and the first step to doing one of these massive studies is to clean the data. But what we found as we went through to clean these data sets is that the distribution of these cardiometabolic risk factors in the YKHC data set did not match what we would see in these standards that are based on populations from the low urban settings in the lower 48. And I think this is probably true of many settings where this type of research would be going on, is that we have standards that are developed in urban academic settings in the lower 48, and we use those settings across all research environments, whether or not they are applicable or not. And what we see is that HDL levels are a lot higher in the YK delta than they are in the NHANES data, which is based in the lower 48. And the triglyceride levels are a lot lower. So if we were to use the standards that would be developed from the NHANES data, that would not be appropriate for this setting. And so our first step was to try and figure out, is there a way that we can bring some of these CBPR type principles to this data cleaning process? And often I think of EHR data as being this sort of amorphous, faceless thing that is not attached to individuals. And the CBPR process is all about individual participation. Right? So how can we take some of that respect to individuals in a research project and apply it to this amorphous cloud of ambiguous data that comes from this general population? And that's where this phenomenological approach comes from. So my graduate student, Sarah Y. Buchanan, developed this approach. And the goal was to create a more equitable and culturally responsive approach to electronic health record research. And the goal was to allow the unique experiences of each individual to remain in a data set that otherwise might be excluded using these standard protocols that we use to process EHR data. And the result of this is that no individual is excluded from analysis. And this seems really important because if you're including someone in analysis, you don't want to make any judgment on whether they should be included or not. And so is there a way that we can high throughput clean data in a way that still maintains respect for every single person who has contributed a data point? And the way we did that was through 3 steps. The first, and this is just was sort of a basic approach. In the classic data cleaning process, you would truncate outliers that seem biologically implausible. But that assumes that you know what is biologically plausible in a population, which we saw in this previous table is not the same in every population. So what we did here instead is just to exclude values that are biologically impossible. So this is something that we saw in the data set where we would see, for example, a height of 2. And we don't know what that means. If you do 2 inches, that's clearly there's no person who's older than 18 years old who's 2 inches. There's probably also no person who is over 18 who's 2 feet. And so that was a way where we consulted with people who were actively engaged in the community. So Bert and Scarlett, who said, you're right, there is no way someone who in these communities over 18 years old and lower than and would be 2 feet tall. So that's something that we would take out. Whereas someone who's 4 feet, maybe, possibly, if you were to use standard methods, you would definitely get rid of a value of 4 feet, but it's not biologically impossible, so we leave it. And this is really the meat of the process, this step 2. You normalize distributions based on intrapersonal variability. So classically, in data cleaning approaches, we would normalize across the entire population. So all observations overall, we would exclude outliers that are outside of 3 to 5 standard deviations from the normal distribution in that data set. Here we take individuals as their own controls for themselves. So within a person who's coming to the medical system many times, you might see, for example, this person in blue has visited the healthcare system 4 times. And each time, 3 of their measures are basically the same. And 1 measure, even though it's within the range of everybody else's, is clearly very different from what their other standard measures are. That measure we would exclude. Whereas these other 3 measures that are maybe outside of the distribution of the other folks in the data set, we would maintain, even though they might be cleared out under classic data. And then the third is an imputation style, just to be able to include more data and analysis. And this we used a lot for adjuster variables, is using an imputation based on the own person's visit. So for example, for our smoking variable, we chose, if someone had a visit that was missing a smoking variable, we would choose their smoking variable from the other closest time point. For something like height, which should be mostly stable over time for 10 years, we would take the average for that person across all visits. So in this way, this phenomenological approach uses each individual as a control for themselves in order to clean up some of the variability in the data set. And what we see here is a presentation of how this affects the data that are included in analysis. So we have a few measures that we can look at. We have the original data set. This is none of these cleaning processes that we talked about. The common methods, which is using everybody as a control for everybody else. And then the phenomenological approach that uses each individual as a control for themselves. And you can see that it doesn't really change much in terms of the data measures. And it doesn't really change much in terms of the conclusions that I'll talk about in a little bit too. But what you do see is that the range in the phenomenological approach between the lowest, the shortest and the highest height, for example, is much broader in a phenomenological approach. You get these tails of distribution that otherwise would be truncated. And you retain every single person in the data set. So you can see in this common approach, you've dropped about 35 people. Whereas in the phenomenological approach, every single person who's in the original data set is still in that data set. So we did this phenomenological data cleaning process, and then we wanted to see this original question. Is there a difference in the rate of change in cardiometabolic health measures between communities that have participated in CBPR research and communities that have not? And we use linear mixed effects models for each of these cardiometabolic outcomes that you'll see listed here. And we can have 2 outputs from this process. One is we can see the mean difference in these communities at the start of the study period. And then we can also see the annual rate of change that differs between study communities and control. And here we can see all of these measures that we looked at, all of these outcomes that we looked at that are related to cardiometabolic health. How many observations per person on average were included in the analysis? and whether there was a significant difference in the rate of change between 2002 and 2012 between the study communities and control communities. And then the final column shows whether the rate of change in the study versus control communities is faster or slower. So these 4 measures at the top, we didn't see any significant differences. These measures, total cholesterol, LDL, HDL, and triglycerides, are measured much more rarely and often in people where a problem is already suspected. So it's not truly a general population sample. Whereas the lower, and you can see that reflected in the number of observations per participant. These bottom 3 measures, the blood pressures and BMI, are measured much more routinely, and so they can be thought of as more of a general community measure. And we do see significant differences in the rate between community members between communities that do participate in research and do not. And I'm going to go into these a little bit more. So the linear mixed effects models, the results that come out of those are really convoluted and sort of hard to interpret in a table. So what we did is we took those results and mapped them back onto this is a projection of the results from those models based on what you would see annually. So how you would interpret this for systolic blood pressure, we see that we have systolic blood pressure along the y-axis, the year along the x-axis. There's adjustments for age, sex, tobacco use, the number of studies that each individual person participated in directly, right? Because we want to capture community level effects, not the results of individual research participation. And then the distance of that community to a regional clinic. The black line shows the projected blood pressure across these years in communities where there was no CBPR, so the control communities. And the gray is the projected blood pressure in study communities. And you can see that the starting blood pressure in study communities was a little bit lower than in control communities. And that systolic blood pressure decreased over time in all of these communities, regardless of whether you are in a community where CBPR happened or not. And this gets at that important temporal change question. Blood pressure is decreasing across this entire region, whether or not CBPR has a process. But we can see that the systolic blood pressure decreased 0.04 millimeters of mercury faster per year in study communities than control. So we're seeing a faster decline in blood pressure, in the systolic blood pressure in study communities versus control. This is very small, but over time, this would have an impact on cardiometabolic risk, strokes, heart attacks. So as the other illustration, we can see this for diastolic blood pressure. Unlike systolic blood pressure, diastolic blood pressure increased in all communities over this study time. But although the study communities and control communities, diastolic blood pressure started at approximately the same level and increased over time in both, the increase was slower in study communities than control communities. And the diastolic blood pressure increased about 0.07 millimeters of mercury per year slower in study communities. So in terms of the blood pressure, for both systolic blood pressure and diastolic blood pressure, we see healthier trajectories in study communities after accounting for the individual participation in research studies. These are small differences, but they're associated with protection from stroke, heart disease, and other adverse cardiometabolic. Interestingly, what we saw is that BMI increased more quickly in study communities than in control communities. We have a lot of theories on why that might happen. I took it out for the interest of time, but we can talk about that a little bit if we have time. So how might CBPR improve overall community health? When we think about the community-based participatory research process, there's door-to-door outreach before the research process actually starts. There's one-on-one participant feedback. There's referrals to the healthcare clinics. And then in terms of how would that information might spread among community members, there's a lot of secondhand health information that's shared from one person in a community to another. There's aggregate outcomes that are presented at tribal council meetings. And what we think is that there could potentially be community advocacy for healthier community level policies. So for example, advocating for different school lunch programs or inclusion of different types of foods in the local markets. And through this process, there might be a sustained increase in community-wide engagement. So I think there are several key implications of this project for future research. The first is specific to the CBPR process. I think we see that it is a really powerful way to engage communities. And I think that's been shown many, many times on the short-term scale in terms of respect for research participants, trust in the research process. But now we see that it could potentially also be a useful tool for just improving health engagement and health outcomes in communities generally. It might be a really positive way to engage with communities worldwide in terms of promoting healthy lifestyles. And then this phenomenological approach, so the specific method for dealing with these big data sets is that we can still clean data in a way that we often think of as being really anonymous and not reflective of community values per se. There's a way we can do that that still honors participants without compromising the data integrity or the study results. So if we're increasing and improving respect in research, we can use CBPR to gather the data, and then we can use this phenomenological approach to clean it. So I'd love to answer questions at this point. I think this is a really exciting prospect to be using CBPR in as many different avenues as we can. I think it's hard to scale. And so if we can think about creative ways to apply those principles to many aspects of our research process, whether that's conducting the research itself as the CBPR was designed to do, or whether we can modify those methods in some way to fit something like data cleaning, big data analysis, machine learning. I think there's a lot of exciting possibilities and potential there.
Thank you for that talk, Allison.